Hello and welcome to the Heartline Report ESC Download, What's New and What's Next. My name is Manesh Patel, and I'm excited to be joined by a friend and colleague. Jen, thanks for joining me.
Thank you, Manesh. I'm excited to talk about all the things we learned at ESC.
Yeah, and welcome to our audience joining us on social media. Please feel free to comment and ask questions. We'll try to answer the questions as we go through this. Lots of great information, some positive, some that we didn't anticipate. So maybe, Jen, let's talk about what's new from the ESC and some of the data and the trials. I know you and I were at some of them, so maybe we go through some of them there for our audience.
Yeah, so I think a lot of exciting new data within uncontrolled and resistant hypertension. These patients are very difficult to treat, as you know, from clinic. And so I think Bax hypertension, as I remember in the audience, got an audible awe when the results were demonstrated. So patients with systolic blood pressure above 140, below 170 on multiple agents already, so refractory hypertension, really got either Baxdrostat 1 milligram, 2 milligrams, or placebo. And you can see that there was actually a significant reduction, 8.7 millimeters, 9.9 millimeters for the higher dose compared to placebo. And so interestingly, Manesh, when you look at it overall, both doses achieved about a 40% of patients with controlled systolic blood pressure versus just 18% in the placebo. I think that's really remarkable. What do you think?
Yeah, I think first and foremost, I think a lot of this meeting and many meetings to come are going to focus on, which is, I think, a great time for us, which is new therapies in hypertension. For many years, we've had just limited therapies. And so, as the leading modifiable cardiovascular risk factor across the world, it's really exciting. And the aldosterone synthase inhibitor Baxdrostat shown in this trial, again, to be, interestingly, on top of other therapeutics, to be effective is valuable. We know there's a placebo effect. We've seen it in other trials. We saw it in this trial, and we saw beyond that placebo effect significant reduction. So I think that was really promising, and obviously we'll see how the field goes. But I think it's great to have more more arrows in the quiver, if you will, for patients with difficult to control blood pressure.
Cardia 3, obviously neutral trial of an angiotensin RNA interfering agent in a high-risk CV population, plus or minus chronic kidney disease. So didn't see any significant reduction compared to placebo at 3 months, but obviously my understanding is now looking at other subpopulations where there might be a signal and improvement in this drug. What are you thinking in terms of the future for Cardia 3 and other trials?
Well, I think, it didn't meet its statistical significance endpoint, but it is important to recognize that this, again, another complicated study presented by one of our colleagues, Neha Pagapati. 375 uncontrolled patients in a phase 2. What we did see some signals for people that might need to be on a diuretic that might get a bigger benefit, and that makes sense with some of the mechanism. Really exciting here because you have a long-acting, a small interfering RNA molecule, a long-acting high blood pressure therapy. So you can imagine over time there's going to be even greater effect with adherence. So I think it informs the study design for their large cardiovascular outcome trial called Zenith, and I think that's really going to be valuable because getting cardiovascular outcome trials with these blood pressure agents really will move us forward.
And then on to cholesterol. So I thought cholesterol and anti-inflammatory and LDL reduction still sort of took the day at ESC this year. So I know you have a lot of experience with an ongoing program right now in inclisiran, but Victorian difference, I think, really interesting. So 1,770 patients, primarily European population, randomized to inclisiran versus placebo, and you can see almost 85% achieved their LDL target, their individual target in the inclisiran versus 30% in the placebo arm. And obviously what we're all trying to avoid are these muscle side effects with the statins that oftentimes really hurt our patients or cause them not to take the medication. So what do you think the future is for inclisiran? And I know you have an ongoing trial right now you're working in inclisiran.
Well, I think the opportunity for all of these agents is to get people's blood LDL as low as possible, as fast as possible, because I do think that will hopefully help our patients. And Victorian difference shows us that early and sustained reduction with not as many side effects as you mentioned. So we know that now in several different groups, inclisiran is able to achieve LDL reduction. We have both secondary and primary prevention trials ongoing, and then trials in revascularization space. So I think we're going to learn a lot more on outcomes in this space, but we know that it's effective and tolerated well.
And then the hypertriglyceridemia. So we don't have a specific drug, as you know, for this, and many patients are plagued by this. And so Essence TIMI 73B presented at ESC of olezarsen in patients with a median triglyceride of 238 and saw a reduction by 60% in those treated with this agent compared to placebo at 6 months. And importantly, one of the things we always worry about related to triglycerides is acute pancreatitis and other side effects. Really didn't see a high signal for this. So maybe potentially an agent to try to use for patients with really high triglyceride levels.
Yeah, I think it's exciting. This is an exciting time for cardiovascular cardiometabolic prevention, right? We just went through some blood pressure studies and LDL and now triglycerides. There's going to be some LP(a) studies coming again, as we know. Importantly here, we've had lots of interest, and now we have an effective phase 3 study showing us that you can reduce that triglyceride event in these patients, which is important, and it lowered the rate of MACE. So, we're starting to see outcome data too, so that's exciting.
And then I think in the heart failure space, while there wasn't, these two trials that are listed here were neutral overall, still think it's really important to discuss. So DAPA-ACT heart failure TIMI 68, again, another trial of DAPA in the hospitalized heart failure patient, didn't meet its primary endpoint, but there was a numerical reduction in CV death, which I think is important to note. I think it's still potentially an important drug in this population. Similarly, Victor, vericiguat, looking at potential reduction in patients with HFrEF without recent worsening, didn't meet its composite endpoint, but when pooled with data from Victoria, there seemed to be a benefit in sort of all-comer heart failure patients. So I think a story is still out there for these two drugs potentially.
Yeah, I think this is, again, the evolution of what's going on with our heart failure area for sure. We've known from many trials that SGLT2 inhibitors reduce cardiovascular events, and the question's always sort of been where and how and where do we use it? What are the indications? And DAPA shows us at least that initiation in the hospital may have some signals. It was safe and well tolerated, but it didn't get to its primary endpoint. So I think that's important for us to think about. But we know long term it's valuable, and it's a bit about how you get it started. For Victor, I think the message is interesting in that vericiguat, in the pooled analysis has an all-cause mortality reduction. So that really does make me kind of interest me, but the primary endpoint wasn't met in the analysis. And it makes me try to understand the mechanism if all-cause mortality gets better, but we don't have a heart failure opportunity. So just some thoughts for us, but really great studies. And maybe we go from these to a couple more from the late-breaking science at ESC.
So I love thinking about Smurfless, the concept of Smurfless. I think, this is a great study presented by Paul Ridker, published in The Lancet. This was a large population of healthy women, predominantly in the women's health study, over 12,000. And these are people that have not had a cardiovascular event, but have elevated hsCRP, so 3 or more, which we know places you in high risk from an inflammatory perspective. And you can see really high rates down the stream, and they have the benefit of long-term outcomes, high risk of total CVD events, of ischemic events. And so I think still the inflammatory hypothesis is alive and well. We've just got to figure out a way to target it and affect it.
Yeah, I know you and others are involved, and there's ongoing studies around the inflammasome and therapies to do it, but this shows us that there's still an unmet need for sure.
Yeah, so I think exciting there. And then retreat frail. So I take care of a lot of older patients living in skilled nursing facilities who may be at risk for falls. And I'm constantly thinking, should I down titrate their antihypertensive regimen to affect that and to affect their overall outcomes? And very nice trial conducted in France looking at patients on multiple agents and using an algorithm to down titrate their number of antihypertensives. Now, they didn't see any difference in terms of those with standard of care versus those that were getting down titrated in terms of their antihypertensives. But in fact, that may actually tell me that if there's really no difference there, maybe both strategies potentially are useful, and it might still be okay to think about fewer agents in this population.
I think it's always okay to think about it, and I actually think you're right. I don't know how much we know exactly around the safety, but we know that that it seems similar in event rates. And obviously, if you're in a nursing home and your blood pressure is less than 130, many different medications will have different blood pressure effects. So I think down titrating is a good exercise to at least try, and if you can do it in a safe manner in a observed place. Well, one thing we might think about, do we go on to the guidelines that were updated? And while
Yeah.
you're bringing up the guidelines, we'll keep answering questions that people have. I see a few coming in, so maybe you go through the update of dyslipidemia guidelines, and then I'll answer one of the questions that came in.
A lot of excitement. So obviously updated from the 2019 dyslipidemia guidelines from the ESC, some important updates in this 2025 update that was, so we now went from the SCORE to SCORE 2 and SCORE 2 OP in patients greater than 70 years of age. And this includes things like, their age and their systolic blood pressure, their total cholesterol and their HDL. So include some important risk factors to try to give us a sense of the very high risk and the high risk patients that we should be really focusing on. Certainly, with any of these SCORE predictors, I think a lot of it is you need to take it into to the sense of what you're seeing clinically, the whole patient presentation. This doesn't, a score that's elevated on SCORE 2 or SCORE 2 OP doesn't necessarily paint the entire picture for me.
Yeah, I think what it does highlight for us is that the guidelines highlight the importance of getting cholesterol measured and scoring patients and thinking about that. These additional risk factor modifiers, as you said, Lp(a), we've known for some time some high-risk ethnicities like South Asian or obesity are important. So I think the guidelines are helping us here at the ESC. But as I said, when we were talking about this, there's a SCORE 2 risk score, there's the prevent risk score. How do you think about these risk scores? In my mind, I think when we're thinking about prevention, we're thinking about certainly lipids, and this is the dyslipidemia guidelines, but we're thinking about preventing all of the events and how we might think across those. So I think that's important for us to think through and will be continued to be important. Maybe you could tell us a little bit about other additional risk factor modifiers that people had in these guidelines.
So I think, they were very smart to think about other risk factors, except for the ones that we sort of traditionally think about that are in these scoring systems that you mentioned. Obviously, your family history, big impact about what you might experience down the road. Things like sleep apnea, inflammatory disorders. I'm constantly curious with my patients with RA and other inflammatory disorders, just their CVD risk is quite elevated. Stressors, I think we don't focus enough on sort of systemic stressors in our patients and their psychiatric disorders and the role that might play. So I think this was a nice way to look at the overall patient and figure out how we treat them individually.
I think so too, and this is important because I think it'll guide our decisions a little bit more, and we can continue to personalize. These guidelines and others have really pushed us to think about the whole patient and the way to do that. In fact, the other thing I'll highlight from the guidelines was that they also highlighted for us that in addition to the standard lipid lowering agents, we should be thinking about adding the others here, as you can admit and see. Bempedoic acid, for example, from the CLEAR outcome studies, and others now have guideline recommendations in addition to statin or people who can't tolerate statins to get therapy. And then lipid lowering therapy at the time of hospitalization for ACS. We always say if you're on some, it's not enough if you had an ACS, so the guidelines now follow that, intensify. Or if you've never been on any and you come in, at least getting to an intensive dose to get you towards guideline recommendations, I think really does move the needle. I didn't know if you had other thoughts about that, Jen, but I think those were important sort of move forward. And I guess, how will you incorporate some of this new information into your practice?
Well, I was excited. So even though bempedoic acid is not a new drug, as you know, it's primarily, I think, being used in lipid clinics and not in more general sense. And so I was excited to see that now it's becoming sort of more of a mainstream agent that the general cardiologist may turn to more frequently if they're having a hard time with a statin intolerant patient or a patient that's not met their LDL goals on statin therapy. So I think that that's an important move. And then really just understanding that the time of hospitalization is really a great time to affect change and what you may or may not do for the patient that may not come back as an outpatient too frequently. So I like that there's a real focus on trying to get patients on ideal therapies early on.
Yeah, I think that's really key. It's never too early. It's never too late. Well, that was a whirlwind tour through a lot, and we're almost out of time, but we're going to be going a lot deeper into some of these data and guidelines this year at our next an important 6th Annual Cardiology Conference, the Heart of Cardiology Conference at the end of January in Miami, Florida. I'm honored to be able to do this with Fatima Rodriguez and Jeffrey Barnes and others like yourself who come to this. So we really hope you guys get to come to that. It's a great conference where you get to mingle and learn from others and really spend a lot of time diving deep into these issues.
Thanks, Manesh. This is great.
So please, if you get a chance, thanks for participating, and scan this QRS code and make sure that you get credit for watching this event and hearing about the updates from ESC.